Good afternoon, everyone. Good afternoon. Thank you very much for joining this afternoon session of the Introduction to Cancer Epidemiology module of the IARC Summer School. So this is the first day of our face-to-face component of this module, and this is the second state-of-the-art lecture of this module, and the first one that is being organized during the face-to-face part of the summer school. So this afternoon we have the great pleasure of welcoming Dr. Salvatore Vaccarella, who is a scientist at IARC since the year 2000, and he's currently leading a research team focused on social inequalities and cancer within the cancer surveillance branch at IARC. He obtained his PhD in statistics at the University of Milan, and he joined IARC first as a visiting scientist and a postdoctoral fellow, and was then recruited as a scientist in 2003. His research interests focus on global cancer transition, social and gender inequalities in cancer, and on relevant mechanisms in the provision of equitable healthcare services. Salvatore has been the editor-in-chief of the IARC report on reducing social inequalities in cancer, which I invite you all to download and read, because this is really a wonderful book if you want to get into social inequalities in cancer. And his work has also been instrumental in demonstrating that the current epidemic of thyroid cancer diagnosis is largely due to overdiagnosis. I also invite you to read his articles on that. And today he will be talking about social inequalities and cancer. So Salvatore, the floor is yours. Thank you.
Thank you very much, Laure, for the nice introduction, and good afternoon to everyone. It's a pleasure for me to be here, and we are lucky, the lucky ones, to try the new room of the IARC, the new building for the summer school. So I'm very glad to be with you. And so today I'm going to talk about cancer inequalities. I will provide a general overview and also with some flavor of what we do in IARC, what we've been doing in the past 3, 4, 5 years. And so the topic is very wide and is developing more and more, and there is more and more interest in this topic everywhere. So it's something that probably we will hear more and more in the future. So I think I can start with this small introduction. So this is the general framework that this talk will follow, and also our work somehow follows these 3 major areas. One is we can call it global development, and has to do with cancer transitions, but not only cancer, but all the transition, epidemiological transition, and whatever happens at the country level. And I will show you an example. And so as countries develop towards better socioeconomic conditions, we see that this is, of course, very good, but also there are some negative effects, like an increase in amount of cancer, not only in absolute terms, because people is getting older, so there is a larger number of people getting cancer, but also the rates. So this means also that there is an increased exposure to some risk factors and other factors that might lead to this increase. The second part is the more classic traditional study of socioeconomic inequalities, and has to do with the inequalities within countries. And here we see no matter what study you find, in no matter what setting, we see that as the socioeconomic condition of the individual decreases, the amount of cancer, any health problem is increasing. So, and this we see it in every country. But what we will try to show later is the importance of having comparable data across countries, so that these inequalities exist everywhere, but they might be more or less pronounced in different countries. And the last part that Laura was mentioning has to do with inefficiencies in the delivery of healthcare. And so at the same time, we have the coexistence of an undersupply. So we don't have enough medicine, enough intervention for those who are on the lower end of the society, of the poorest countries. On the other hand, we see that there is an oversupply that is demand-driven and is leading to a number of interventions that are either not very effective or could be even harmful. We will see an example later with the thyroid cancer. So this is the general framework of this talk and of our research. And this is the outline of the talk. So the first topic is the global development and the epidemiological transitions. 1 second, I need to find the right. And then the impact on the magnitude and profile of cancer at the country level. So in this first part, we talk about country level inequalities. So as mentioned before, life expectancy has been increasing in the past 50, 60, 70 years in general, because we see also some declines recently in the US, in the UK as well. So there is something that probably is going on at a wider level. But in general, we see the life expectancy has increased a lot. You can see the panel on the right side. And this is good, of course, but we see that we will see that has consequences on cancer as well. There are other factors that have changed dramatically in the past decades. One, for example, is fertility, and you can see on the left side, fertility rates have declined massively in the past 30, 40, 50 years, and are still expected to decline low resource settings. Fertility is a risk factor for cancer, so it's particularly important for us. But there are other factors like urbanization. Let me see if I can manage to. There is some, I cannot manage to do the dynamic part of the slide. Doesn't matter. I don't think we can do it right, the action. It doesn't matter, okay. So urbanization, you were supposed to see a slide that is increasing with time. Urbanization is increasing with time in every setting. But so people live more and more in the cities. Before 50 years ago, people were living more in the countryside. Type of job change. Urbanization might be good for certain things, increasing production and living better, but not for everyone. Some people do not find their place in the cities, are exposed to a number of increased exposure to a number of risk factors, air pollution, and so on. So these are just examples of the so many phenomena that some of them are directly and some other are indirectly related to cancer. One important indicator that is used to summarize human development is this Human Development Index, HDI, has been developed some time ago by the UNPD and has been very used in many studies, and we also use it very often, and it has 3 dimensions predominantly. One is life expectancy, the other is the education level, and the other, the average education level, and the other is the income, basically. So many factors are correlated. So this index trying to summarize with only 3 dimensions a very large number of phenomena that are occurring and that are all correlated. And this, somebody estimated the historical index of human development, and this is of interest because we see that whereas this is increasing everywhere, so we see that basically in all the countries there is an improvement, but there is somehow a shift. Some countries like the Nordic countries or more high-income countries like Sweden, for instance, they have a very high level, Norway as well, and other countries. And so-called emerging economies like Brazil or China, they are following, with respect to this parameter, with this indicator, they're following with a delay of 3-4 decades. But we can, so this is interesting because we can expect that somehow there is a similarity in the path that, between countries. So we might expect that China and Brazil and India eventually will follow, to some extent, the same pathway of the US or Sweden. So this is, so finally we talk about cancer and what is the impact of socioeconomic development on cancer. This is quite complex because as you can see in this slide, so the x-axis, they show national socioeconomic development, and we see, and on the y-axis, we display incidence and mortality. So each country is represented by 2 dots. The blue dot is incidence, and right down below there is the red dot that is representing mortality. We can see that as the socioeconomic development of the country increases, there is a very large increase in incidence. So incidence cases of cancer are increasing a lot. You can see again the example of Sweden. In Sweden, the incidence of cancer is very high. So we do not see the same with mortality. Mortality is more difficult to find out, at least when we talk about countries. So, and we try to understand, it's not completely clear what are the reasons of the increase in incidence and the relatively flat mortality, the fact that mortality doesn't change much with socioeconomic development. So for incidence, we know that there is an uptake of risk factors. So as countries become more developed, people, and we will see later in which socioeconomic group, but in general, people start to smoke or to have unhealthy food, or become obese, eating more. There is more possibility to have food. So sometimes there is exaggeration, and so there is a number of exposure, pollution, a number of exposure that make incidence increase. On the other hand, these countries that are fully developed, they benefit more from screening, early detection, better treatments. There has been a lot of improvement in treatment, so they benefit. And these countries, they have invested in the past, when there was the economic boom, they invested a lot in treatment and in health system and so on. So these could be some of the factors that could explain. There is also competing causes of death, because people live longer, so they develop several diseases, and maybe some people develop cancer, but they die from another disease. There is a bit of overdiagnosis as well for some cancer. We will see later the case of thyroid cancer. So it's quite complex, the picture, but it's very interesting also to have this in mind. These are data from IARC GloboCan. These are all data 2018, but you can still see the same picture for 2020. And now soon we will have the new GloboCan 2022, but probably we will see the same picture. So it's not very clear. There are a lot of interesting features. Yes, this is a methodological feature. In our previous slide, we didn't use the HDI as indicator of socioeconomic development, but we used another indicator that we build that is based not on 3 dimensions, but only on 2 dimensions. So we removed the life expectancy dimension because life expectancy is correlated with cancer mortality. Cancer mortality has an impact on life expectancy, so we didn't want to have an indicator that is built on something that depends on cancer mortality. So, but from the practical point of view, there are no differences. It's just a methodological issue that we had to do when we analyze cancer incidence and mortality. And this is the profile. So this is somehow the same picture we've seen before, but for specific cancer. We see incidence rates for 184 countries by socioeconomic development. We see that for most cancer, there is an increase in incidence for most cancer. So the blue part, where the most socioeconomic developed countries are, is on the top. So most developed countries, they have more cancer for most of the cancer types, but not for all. For instance, cervical cancer or liver cancer or stomach cancer, this is more incident and prevalent also in low middle income countries. And this is the same figure for mortality. Again, the pattern is similar for cancer with a bad prognosis, like lung and pancreas and so on, but is more mixed and is not that clear, as we explained before. So the association of socioeconomic development with mortality is more mixed and more difficult to interpret, at the country level at least. And this is a figure, is the same, is a map that shows practically the same thing, but in Europe, and shows that basically, for incidence, we have more incidence on the west part of Europe, and the north and west, where countries are more developed. But in terms of mortality, you see Eastern European countries and Baltic countries, they have higher rates of mortality. Despite the fact that they have low rates of incidence, they have higher rates of mortality. This shows a little bit this kind of interesting pattern when we talk about socioeconomic condition and cancer. And why I showed you Europe, because the next data, the next part, socioeconomic inequalities in cancer, the data that I will show, they are predominantly in Europe. So it's important to keep the general picture in mind. So before going into the data and the second part, which is socioeconomic inequalities within countries, it's important to mention the structural determinant of health and of cancer. So any behavior, individual behavior, is strongly affected, impacted by the environment, so by social, economic, environmental factors, political, anything in our society is affecting our behavior. Of course, not totally. We still have some possibility to do something different, but you will see the example is a football pitch that represents somehow the structural determinant of health. So is more favorable, the society and the field, the football field is more favorable to some people, to some players. So those one with the red shirt, for them it's easy to score a goal because the field is unlevel, so the balls always go down. For them it's easy. For other teams, and the same for people in the society, and especially with respect to staying healthy, it is more difficult the yellow team, for them is difficult to score a goal. So this is somehow a way to represent the structural determinant of health. For some it's easy, for some it's more difficult. This, we see this behavior, this structural determinant in every country, in every population. But what is interesting, and that's why it's important to have comparable data across country, is the steepness of this unleveling might be very different. So we see inequalities everywhere, but we can still modulate. It is possible, depending on how to structure your society, to modulate this slope, the slope of the field. So, and I will show you an example very soon. This is something that we've been published recently, and is one of the few studies that is in collaboration with the Erasmus MC in the Netherlands. They've been collecting a unique set of data, the Erasmus MC. And the interesting thing is that they are comparable across countries, across European countries. And why is it interesting? Because it shows the slope of the football pitch. I'll show you now. So we just published recently, and there are not many studies like this. There are a lot of studies on socioeconomic inequalities and cancer in different countries and population, cancer types, but having a comprehensive and comparable, especially, study is very, very rare, because there has not been much investment in this kind of data. So I always want to say that this kind of data are super unique, are very unique, and we need to thank the Erasmus MC for having done this activity for many years. So this is the data set, is always ongoing. It's called the metric life path data set. Has been collected and harmonized by Erasmus MC, Dr. Wilma Nassender, who is going to be actually in IARC from today for the next 2 days, and Professor Johan Mackenbach. So they collected harmonized data. They have a harmonized data set on cancer mortality by education level. This has been built by is census-based, meaning that they followed up after each census every 10 years in every countries. They followed up people and linked this information with information from information on mortality. So sorry. The information on education from the census was linked with subsequent mortality, so we could link mortality with the socioeconomic status for many countries. And it also includes national populations, almost the entire population, and this is also important because many retrospective studies or prospective studies, they somehow suffer from the LT cohort effect, or they are slightly selected, which means that it's very difficult to have in these studies people with very low socioeconomic status because you don't reach them or they do not feel like to participate into this study. So that's why this is important. It includes for most of the countries, 99% of the people, so the age is 40-79. Observation period is quite long, so we can also do trends. Goes from 1990 to 2015, depending on the countries. And the next slides present just a glimpse of this data only for a period that is around 2010. These first slides includes all countries pulled together, and is important because it shows that every cancer type is affected by socioeconomic inequalities. So the rate ratio for low versus higher education goes from close to 1 to up to 3 for cervical cancer, 4 and 5 laryngeal cancer. In particular, smoking-related cancer are associated with inequalities, but also not only smoking-related cancer, but also, for instance, cervical cancer. So the rate ratio here is 3 on average in Europe, but of course there is much more variability. In some countries it's much higher. We will see an example very soon. But so, socioeconomic inequalities affect every type of cancer, basically. The second, the other figures are disaggregating by country and by cancer type as well. So these are just total cancer on the first 2 panels. Then we have lung cancer and pharyngeal cancer. I'll show you other slides later. So the black dot represents low education. The white dot is high education. And we can see that in every country, so the countries are the bars, basically, the initial, the acronym. In every country there are inequalities for every cancer. So because the black dot is on top of the white dot. And there is also the so-called social gradient. So the gray, medium education is almost always in every country and for every cancer is in the middle. So this means that everyone in the population, every citizen is affected by socioeconomic inequalities because everybody could have an improvement in their own health condition, or in this case, cancer mortality, could reduce cancer mortality. So this is, the next one is another batch of figures that we had. Colorectal, for instance, we see a similar pattern, stomach, men and women, liver. There are inequalities everywhere and for every cancer. These are, in our study, we estimated that it's important to do it when studying socioeconomic inequalities in cancer, absolute and relative differences, because in some cases they might go in a different way. So especially if the trends are declining strongly or increasing strongly, it's important to have an overview of the absolute and relative differences. In this case, in our case, there were no major differences between absolute and relative measures. But what we've seen was that for men, there were a lot of, the inequalities were larger in East Europe, and lower in Mediterranean, South European countries like Italy or Spain. But for women, the picture was a bit different. So Eastern European countries always showed relatively high inequalities, but also some Nordic countries, Denmark, Norway, they show a lot of inequalities among women. So this is very interesting, and it is also a bit worrying in the sense that usually the Nordic countries are known to have, social policies and so on. So this means that inequalities may happen everywhere. This is cervical cancer, and is one example that I use very often. There used to be some special effect, but apparently it doesn't work. Anyway, so cervical cancer, we see a similar pattern. So we see that there are inequalities in every country, but there is a large variability in these socioeconomic inequalities. Okay, so in every country we see inequality. So the black dot is on top. We see a social gradient. The gray intermediate education is in the middle, so everybody is concerned. But what we see, what is interesting here, there is a large heterogeneity in these inequalities. And but we see that for high educated women, the mortality rates are always relatively low and similar everywhere. So it looks like for high educated women, they know, women with high socioeconomic status, they know how to defend themselves. For instance, they might go for screening, they might look for information and how to prevent this cancer, or they see the doctor very often, and so they know how to defend themselves, protect themselves from cervical cancer to some extent. What is impressive is when we go to low socioeconomic women. So in some countries, the countries on the left, they still have relatively low rates, mortality rates, which probably means that they organized the system of organized screening is capable to reach them as well. So they also benefit from screening, perhaps in some countries where screening is organized and so on. But in other countries, like those one on the right side, which happen to be Eastern European and Baltic countries, for these women, the risk of dying from cervical cancer is very high. Is as high as sub-Saharan African, and I mention this because we see the higher rates of this disease. So it's important to see that also who are the social groups that suffer the most, even in European countries. And this also explains somehow part of the differences between countries. No, we talked before about differences between countries. So somehow what happens inside the countries has also an effect on what happens between countries. And this might be also have an impact for the WHO Cervical Cancer Elimination Initiative. This is a WHO initiative that would like to reduce the incidence of cervical cancer to 4 cases per 100,000 in every country. And you can see, this is a study from Dipindra Singh, which is down there, and shows that many countries, particularly in low-middle income countries, settings are well beyond these thresholds or the WHO initiative. So the implications are probably also in these countries, although we do not have the data, but it's mainly low socioeconomic women that suffer the most. And that, so probably they should be targeted more in order to reach this WHO goal and to reach successfully the elimination initiative. Okay, let's go back to our data, the European data. And this, again, we focus again on women, and there is a reason, because we see a lot of inequalities in women. This is lung cancer mortality in Europe, and we can see from this slide that actually, probably paradoxically, the highest inequalities are in Nordic countries and in countries from the north, whereas Mediterranean countries have less of these inequalities. So what does it mean? And this is another study I show, and on the other hand, also they are increasing. So the rates of lung cancer for women, they are increasing. This is a study in the Nordic countries, and they are increasing, but they are particularly increasing in low socioeconomic status women. So, and this might be the impact of the epidemic, the delayed epidemic of tobacco that we see now, the impact. Now, before the epidemic first affected men in Europe and in the US, then men stopped a little bit, but then women, emancipation of women and so on, there was a culture of smoking. And so, and now we see, unfortunately, the results, also for Nordic countries, which is, we see a strong increase, and particularly in low socioeconomic women. And this, again, is quite, not paradoxical, but it's quite unexpected, at least because Nordic countries are well known to, provide social policy and welfare and so on. So, but this means that socioeconomic inequalities might have an impact also in countries with a very high level of welfare and socioeconomic policy. So, it's always important to monitor them and to think about that in terms of research, but also in terms of policy. Okay, in our study in Europe, we found that almost 32%, 1 out of 3 and 1 out of 6 men and women were cancer that were associated with socioeconomic inequalities, but in Baltic and Eastern European countries, this proportion increased up to almost 1 in 2 men, death in 1 in 2 men and 1 in 4 women. So there is a lot of room to work here, and this also gives the potential to prevention, no? Because there is no reason why the same in the same population to have such strong inequalities. If you can prevent cancer for some segment of the population, you should also be able to prevent it for the other segments. Here is a methodological limitation. Education is, we use the education as an indicator of socioeconomic position. Education is a simple measure, has a lot of limitation, of course, we are aware of it, but it is still very easy to, it's the easiest to collect at least, and it has many advantages that probably, yeah, it's easy to collect, is a good proxy of also of health literacy, and is relevant for both men and women, and yes, it doesn't suffer from reverse causation. So once you reach a certain education level, you cannot go back, so there is no risk of reverse causation. It's fixed throughout life, and so it has a lot of advantages, but the most important one is that it's easy to collect if you want to do this kind of comparable studies. And then, of course, you can stratify very well the population according to the cancer burden. We've seen that before. So what are the consequences? So again, gender inequalities in cancer. This is another point that is important. We've seen that women in particular are affected by socioeconomic inequalities, and this will happen probably more and more. And we see this when we, for instance, focus on younger adults, which are adults below age 50. And if you take the global current data set, and you just simply, you can simply see this by yourself, you just select younger population, men and women, and you see that most of the cancer are already occurring in women. So 2/3 of cancer diagnosed within this age range, 2049, occur in women. The 3 most important cancers contributing to this are breast, thyroid, and cervix for very different reasons. But we will see thyroid later, but all of them have very catastrophic consequences. And this is a study that was done here in IARC by Florence Guida, and was published last year, I think, or at the beginning of this year. And have looked at what are one of the most important societal consequences of inequalities. So the number of children that remain orphaned from the mother side due to cancer is quite elevated, is about 1 million every year in 2020, with a prevalence of 7 million. So every year there are 7 million children that are maternal orphan due to cancer. And this is important because you can imagine these children might not have, most of them might have, a difficult life. And so this shows the mechanism to which inequalities they perpetuate over the generation. So it's a very interesting study. The last part has to do with so we've seen inequalities between countries and within countries. And we've seen that there are still a lot of inequalities that are avoidable. So our health system are not capable to reach all the segments of the society. On the other hand, there is the paradox that some people, those that are more possibility to access the health system, they have too much medicine, too much care, to the point that this is either not necessary, but very expensive, or that is even harmful. So those who need the most, so this graph shows that people in the society that need the most medical care, they receive less, and the opposite is true. So those that need the least, they receive too much. This is the case of thyroid cancer, overdiagnosis, which we've been working a lot on it. This was a very rare cancer until some time ago, and very few people die, even now. But suddenly we've seen a massive raise in the incidence rates of this cancer, and people started to wonder what it could be. But in the end, I think now it's clear that most of these increases in incidence were due to the fact that there was the possibility to detect very, very small cancers in the thyroid that most of us have. The prevalence in autopsy studies between 10 to 20% of this nodule that they don't do much, no? But because the number of ultrasound machine was increasing, especially in rich countries, starting in the US, France, Italy, in the hospital and in clinics, people had more and more possibility to use ultrasound and magnetic resonance or CT scans. They start scanning and looking for this type of cancer. It's important to say that also the surveillance increased. So screening is very important if it's applied when there are benefits and harm. If it's applied on a not on an opportunistic way, but if it's applied properly in a very well organized way. Otherwise, there are dangers in screening without any criteria, especially for a disease for which screening is not recommended like this one. So there was an increase in surveillance and so on, and so suddenly, I'm afraid I cannot show this, right? I don't think it's working. Oh, okay, it doesn't matter. But anyway, it doesn't work, the automatic. Anyway, it doesn't matter. So incidence rates, this figure is wide, but incidence rates from very low level increased to, let me see if I can make it like this, from very low level here increased to very, 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 very high levels in many countries. I know I cannot make it better than this. Let me see, no, I cannot do it. So in 10, 20 years, it became one of the most commonly diagnosed cancer in women. And now is probably, you've seen before, especially in young women, is very commonly diagnosed. This is another, it was very nice, but I cannot show it, is the age-specific rates. So before this screening, excessive screening was going on many years ago, the incidence of this cancer increased with age, no? With a power law. So The older you get, the more there is an increase of this cancer. But now with this new screening, a lot of young women are diagnosed. So a lot of women around 40, 50, even 20, they're very high, they get diagnosed a lot with this disease. So these empty slides can go now. And this was, so we work a lot on this cancer. We try to find a way to estimate the amount of overdiagnosis. And this is one of the slides. So it is based on many clinical and epidemiological features, but specifically we used the age-specific rates of incidence. So we estimate what was the age-specific curve before the introduction of ultrasound and all this screening, and it was increasing with a power law. And then, as I mentioned, then the shape of the age-specific curve changed a lot. So we used the historical rate as a expected number of expected rates that we would have expected if there was no increased surveillance. And we compare it with what we've seen, and we have estimated that millions of individuals have been diagnosed. This corresponds to 60 to 90% of the recently diagnosed cases, so depending on the country. So this is a massive number. And this phenomenon started in the US, in Italy and France, but you can see in Korea was massive. In only 10 years, with Korean knows this, but there's been a crazy increase of incidence. And unfortunately now it's been extending also to emerging countries, emerging economy, Brazil, China, many countries they see, especially in countries where there is not a very much organized healthcare system, where there is a lot of opportunistic screening, we see that this disease is becoming more and more common. And so this is an example of how things can go bad if interventions are not carried out within a framework that is well organized, but they are opportunistic. What are the consequences? The consequences are very heavy for the woman. It's predominantly women, but also men. So there is total thyroidectomy, which is a heavy operation, and especially people are left without thyroid, so they need to take a hormone pill every morning. Most of them, some of them, about half of them, they undergo radioactive iodine. Then there is a number of negative effect. There is the psychological impact of living with a cancer, especially at very young ages. There is financial toxicity. You can imagine a woman being 20, 30, or 40, being diagnosed. She has difficulty to get a loan, bankruptcy, maybe health insurances, maybe she wanted to plan a certain life and so on, but she cannot do it. And there is for the health system a lot of waste of resources that could be used to reduce inequality. So again, this affects mainly women, relatively young women. And we recently done a study in France where we have estimated that only the direct costs of treatment of overdiagnosed cases was as high, in 5 years in France, was as high as between 60 to 116 million euros. So this is quite a lot if you think this is only for 5 years, and only the direct cost, to which you should also include the indirect cost, which means about an average of 89 days for each person out of work. So there are a lot of costs for societies. So this cost may easily become double or triple if you account for all the costs. So there is a lot of unnecessary and wasted amount of money and so on. So people should be aware about that. Again, this I already mentioned that is increasing a lot in Brazil, China, India, and we did some study also on this, and has to do with when the health system is unregulated, it's not well regulated. So, okay, so just to sum up, I think we are close to the end. So the global agenda on socioeconomic inequality. So these are the main issues we're working on: socioeconomic inequalities, And now the global agenda, which means all the agency, WHO, but also Europe and other institutions, they are realizing more and more. The WHO came out with a lot of endorsement in the past 10 to 20 years, so we are optimistic. This topic is going to get more visibility. Europe also, the European Union has set up the European Beating Cancer Plan, and they set up the European Cancer Inequality Registries, to which also we contribute as IARC. And Laura mentioned before our publication that we did. It is free online, so you can access the PDF. There were many excellent experts. Everybody did a chapter, and it's very interesting read. And so the conclusions, very shortly, are that global, national, subnational inequalities in cancer are large, and socioeconomic factors are probably the single most important factor capable to stratify the burden of cancer between and within countries. So it's always important to keep in mind this. It's important to generate the knowledge and monitor the progress on socioeconomic inequalities. This means having more studies like the one that I showed that can compare the magnitude and the extent of inequalities across countries. There are not many of these studies. There is a lot of room for prevention, because there is no reason that populations that are biologically similar have so many different risks of cancer. So there is a lot of room for prevention. And also, even if you do not work on this topic, but I think one of the recommendations from this expert was that every research program, but also every intervention program should keep into account socioeconomic inequalities and try to reduce them, or at least not to increase them. So this was the end, and to reduce socioeconomic inequalities is important that everybody, the so-called intersectoral, so even sectors that are outside the health system will contribute to that. And to this extent, there was a nice Health for All document where from the WHO, where they stated that increasing the economy is no longer anymore the most important thing, but should be health. That is, so it's no health. Health should not be good to improve economy, but it's the other way around. Economy is secondary to improve the health of the population and individual. So this is quite interesting. And this is, our collaborators. And if you want to read a little bit more, you can visit the website. And thanks a lot. And if you have any questions, I'm here. Thank you.
Thanks for the lecture. I have a question about what's your approach, what's being implemented for thyroid cancer incidentally finding. When there's an incidental finding that there's a thyroid cancer, but the patient clinically is stable and there's nothing, for example, did neck ultrasound for something else, but found to have a nodularity in the thyroid and biopsy taken proven to be papillary thyroid cancer.
Yeah.
Are they going to surgery or just observe the patient? Or
thanks for this question. It's very interesting. The first recommendation is to follow the guidelines, which they say, the American guidelines, but also other guidelines, they say not to screen people that are not, or the general population, not to screen people without particularly a specific risk on thyroid cancer. So most of the people should not be screened for thyroid cancer. This is their official recommendation, even though many still do it. So, in a private sector or even in the public sector, they still do it. And the second is once they find a nodule, instead of operating immediately, if it's a low-risk nodule, what they should monitor. It's called active surveillance. So you just, if you think the nodule is very low risk, instead of doing the operation immediately, like they still do in some places, you can wait 6 months or 3 months and then check if the growth of the nodule is. So it's relatively. So there are already ways to reduce the phenomenon, but what we see is that still the incidence is gone crazy everywhere. So unfortunately, so they're still doing this in many countries. Yeah.
Is there spontaneous regression of those nodules? Because we have other conditions, for example, in pediatric cancer, we have a condition called spontaneous regression of neuroblastoma, which is an aggressive type of kidney cancer. But for pediatric patients aged before 18 months, if it's diagnosed, you just follow the patient because most of the time there's spontaneous regression.
Yes, most of the nodules, they do not grow, or they grow very, very, very slowly over decades, years. So, and some of them, they probably also regress. So the vast majority of them is indolent or slow growing, so very slow growing.
Thank you.
Thank you for great lectures. I'm really interested in the social inequality in cancer epidemiology. So I'm so impressed your report previously. And I have questions about like you already mentioned, in cancer incidence, overdiagnosis and underdiagnosis is a little bit complicated, mixed. In Korea, usually we have faced the problems of overdiagnosis. I think it is more complicated to prevent. Like if under diagnosis, we do more diagnosis and screening programs apart, but like in terms of overdiagnosis, it's kind of culture in healthcare systems. So it's a little bit hard to prevent or change the norms in the country. So if you have any idea or suggestions to prevent or like control the overdiagnosis?
Yeah, but in Korea, I think it's true. The rates are still high, and it probably is difficult to do it. But it was proven that several medical doctors in Korea and scientists, they wrote letters in prominent journals, and they did a lot of awareness, and they had an impact. So the rates after that, so they managed to influence people in the country, and so people were more aware. Clinicians were more aware. Even citizens were more aware that this was not. And so the rates declined in Korea. Then they're still very high compared to what they should be, but there is. I mean, this is a positive sign, in my opinion, that there is a possibility to reduce this phenomenon.
Yeah, thank you. And I commented, like in 2012, you already mentioned after the reported about the fact, it's quite decreased, but it start to increase again. So recent report shows the thyroid cancer is the most highest.
Yes.
Yeah.
Yes, because the problem is that the clinicians, they cannot, it's difficult for them to make them understand this. And I also understand because they don't want anybody to, very few people die of that cancer, so they don't want, to overlook a possibly low-risk cancer that might progress. So they don't want to have anyone dying from that cancer. Yeah. so they are really is a cultural. It's very difficult to change this. Not only in Korea, everywhere. But,
thank you very much.
Thank you.
Thank you for the lecture. So it's just a thought. I would like to have some idea on this graph that we saw with respect to. No, I'll just say as the HDA of a country is improving, we saw that the incidence of cancer is also increasing, right?
Yeah.
Yeah. So what do we expect is usually when a country's HDA is improving, the mortality of a cancer will decrease because of the increasing health system that they have. What if this increase in incidence is because of more cases that they pick or more screening they do, more diagnosis they do, not based on the increasing of the risk factors that is existing? Yeah. If it is because of the second reason, how do we differentiate between these two? Whether it's due to increase in number of risk factors or because of the increasing number of detection of cases?
Yes. there is no answer, so we don't know. But what is the big question was, so like you mentioned, incidence will increase everywhere. It's increasing already in emerging countries. So the big question is what will happen to mortality? Because we know, that's what I mentioned before, in Sweden, Nordic countries, they had the time and the money to organize their health systems because there was economic boom, 60s, 70s, so they got organized in that. So now they are on top of medicine, so they have very good treatment access, so they can limit mortality. So the big question is what will happen when emerging countries will also have very high rates of cancer? Mortality will increase, probably, we don't know, or probably there will be a similar impact if people will die of other causes, no? So there is also competing causes. There is, it's not clear what will happen to mortality, but certainly one of the risks is that mortality will increase because these countries probably they didn't have the same level of investment in the health system as Nordic countries or some currently rich countries. So this is difficult to know. So that's why it's important to monitor always. And yeah.
But if this image goes on like this, I think the mortality in the next years will be also higher because according to this image, you get more incidents and the mortality is the same. So I understand two things from this image. There's no cure for these diseases. Most of the patients maybe live for a couple of years without cancer, and there would be a relapse and the disease progression and would end the story with death, unfortunately, of the patient. Since the number of patients increases within time, and there's still no cure, but we prolong the life of the patients, so the rate of mortality, I think logically it should increase, not decrease.
Yeah, another thing, I mean, we should not also overinterpret these figures. So this should be looked also for specific cancer. It should be looked against the temporal trends now for each cancer, each country. So this is just a simplification for the sake of, so we should not base all our reasoning only on one figure, of course. But yes, we do not know what will happen. It's important to monitor incidence and mortality rates in every country. So add more surveillance data, and we will see what will happen. But certainly already having a very high incidence is a lot of is a burden, economical burden. I mean, it's a human burden, of course, but also economical burden already. And then to limit mortality, you need even more money because you need treatments and screening and so on. So, I mean, it's going to be a big problem for sure. In any case, in every country. Yeah.
Maybe one last question from Rola.
Okay. Thank you for the talk. My question is about economic crisis, and if we can consider it as an socioeconomic inequality. For example, are there examples, let's say, after Greece economic crisis or Italy economic crisis in 2009, what are the changes and incidents pre and post? Because for like recently in Lebanon, what we observed that after our crisis in 2019, we have an increase in incidence of younger age breast cancer. This is observation and not studies. Yeah. So my two questions, could we consider an economic crisis as a socioeconomic inequality? Is there studies, I tried to find, I couldn't find some studies that address this research question. And what's the best way to approach if we want to have this research question?
Yeah, no, for sure. There has been a lot of, I mean, the COVID pandemic has had a lot of impact. So certainly on socioeconomic inequalities in general, and also on cancer. So we've seen the number of screening for certain cancer has declined. Then probably, and there are still studies coming out on what has been the impact on incidence and mortality. But from what I understand, in some cases, in most cases, there has been a little fluctuation, but then things are going back to usual for most cancer. But I haven't worked much on that, but certainly is something that is worth it to explore.
Thank you so much. I think we have to stop now, but Salvo is around, so if you have more questions, don't hesitate to reach out to him. And thank you very much, Salvo, again.
Thank you.